amazing things that you think that you wouldn't forget, but you do eventually. My name is Carrie Noble. This is my husband, Ryan. We're here to share our IVF success story. We were married in May of 2009 and decided we wanted to start a family right away. And of course we thought it would be no problem. We'd seen our friends and family get pregnant easily and assumed that we would as well. A year into trying, we realized this was not the case. My OB referred us to an infertility clinic and our journey began. After hearing our options, we decided to start with IUI. After 2 failed attempts, we decided to move on to IVF. The experience was daunting, and the thought that this was our last resort was terrifying. And I might cry, so sorry for that. The process was tough. The pills, shots, emotions, hormones, and more shots seemed like they would never end. We kept having to remind ourselves what the greater purpose was and what the end result could be. I remember standing in our dining room one time when Ryan had to give me shots and crying and saying I didn't want to do this anymore. And another time I wouldn't let Ryan leave town because I couldn't bring myself to give shots to myself. But we did make it through that phase, and we ended up with 8 embryos. But as the days went by and we were updated on their progress, only 2 remained. We were pretty bummed by this because we were planning on implanting 2. If this didn't work, we'd have to consider if we wanted to start all over again. The thought of never being able to be pregnant and have children of my own weighed heavy on my mind. Implantation day was nerve-wracking. Both embryos were implanted and we were sent home to wait for what seemed like an eternity. Then we went in to have a test to see if we were pregnant. I got the results call at work, and I hurried into our file room so nobody could hear me. I didn't know what my reaction would be. The nurse said that she had good news and she had bad news. The good news was I was pregnant. The bad news was that my numbers were extremely low. She said she'd never seen numbers start out this low and have the pregnancy progress. So I called Ryan and told him that I had good news and bad news and instantly started crying. So. She asked that I come back in a few days for another test. That was on a Thursday, I think, and we went back in on a Monday, so we had all weekend to prepare for that disappointment. We shared with some of our family and went in for the next test, and my numbers had increased, and they kept increasing. And as they went up, we were cautiously optimistic because they still weren't quite where they should be. They were multiplying like they should be, but they still weren't at that level. We did start to get excited about the possibility as we went in for our first sonogram, only to hear that our baby measured in the 3rd percentile. Our doctor prepared us for the worst once again and discussed that there was a possibility of losing our baby. But our little one wasn't going to give up. To this day, she's a fighter with lots of personality. She won't be told no. Mabel just turned 3 in April, and she's up there. It was just turned 3 in April and was joined in January of 2013 by her little brother, Whit. With Whit, we had started the process for our next round of in-vitro, drugs on order and all. Luckily, there was a problem with getting it approved through insurance, so we didn't have to pay for anything because before we began, we had to wait for the right time in my cycle, and that time never came. So we were able to get pregnant naturally with Whit, and we thank God for both of our blessings every single day. That picture's from Whit's first birthday. Mabel's journey into this world was a bit rocky. Our nurse indicated this was a success story that would always stick with her because of how low the numbers started out. We hope our story can provide some comfort and inspiration to others. I didn't know, do you want to do any questions?
You guys got any questions for them, what they went through? Okay. Thanks, guys.
Thank you.
Now Dr. Gelbach's going to share the this section up here.
Good morning. I'm Dr. Dan Gelbach. I'm a reproductive endocrinologist. And as I said earlier this week when I spoke at my son's high school, they were doing biology career days, I said, I have the best job in the world because I get to help people have families, and that's very important to us. It's very important to you. Carrie and Ryan sharing their story because it really highlights a lot of what goes into IVF. IVF many times is viewed as the last resort. And you can't go into that kind of treatment without a lot of emotion. A lot of people invest a lot of money. People do feel it is the last resort. In some cases, maybe it should be the first resort. But today I wanted to talk about it because it's a very important part of what we do for couples. It's one of the most successful treatments that we have. And I also want to update some couples about pre-implantation genetic screening because I think this is something that we're going to see more and more as we do IVF. We're very excited about how it may be helping some couples as they work to conceive. It was more than 35 years ago that the world was really shocked by the birth of the first test tube baby. This was over in England. Her name is Louise Brown. And there were a lot of concerns about what are we doing, how could this happen? But now, more than 1% of babies born in the United States and more than 2 to 3% of those born in Europe are through IVF. It is a very common treatment and very successful. There were two men that were responsible for that in England, Dr. Steptoe and Edward. Their first pregnancy was not a success. It was a tubal pregnancy. Their very first successful pregnancy used no fertility drugs. To time it with her cycle, they had to draw blood every 6 hours around the time of ovulation. They had to do a laparoscopy to recover the one egg, fertilize it in the lab, and then it resulted in a pregnancy. We have come a long way since then, and there are many advances that have made it much more successful. The first reports of IVF success rates in the United States, the first national average was 14%, and there's been quite a few changes since then. There are many, many indications for IVF. The original indications were blocked tubes. If you had blocked tubes, you were not going to get pregnant without surgery, which was not very successful, or IVF. Male infertility is very common. In some cases, it can be treated with medications, through inseminations, but in many cases, IVF may be necessary, especially for men that have extremely low sperm counts. Women that have polycystic ovaries, most of them can get pregnant through fertility drugs, but not always. Some are resistant. The injectable medications can be sometimes very dangerous if not used correctly. So for them, IVF may be by far the safer way to get pregnant as well as the most successful. Unexplained, meaning that, gosh, we don't know why you're not getting pregnant. It's not a problem with the tubes. You're ovulating. The sperm counts are good. We've tried you on medications. We've done inseminations. Maybe we've done a laparoscopy. IVF is very successful for unexplained infertility. And we're starting to see people coming in that aren't having trouble getting pregnant, but they know they have a genetic disease that they may be carrying or could pass on. So they come to us to try to have a child that would not be affected by that disease. IVF is really, it's complex and it's not. We want to quiet the ovaries down. Then we want to stimulate the ovaries to produce a lot of eggs. We take the eggs out, they're fertilized, we culture the embryos in the laboratory to the point where they can be transferred, and then hopefully we'll have additional ones to freeze. Most protocols that we use, we start with your menstrual cycle, you come in for some baseline tests, we suppress the ovaries usually with a birth control pill or something related to that. We often will use a medication to quiet the pituitary so that it doesn't try to release the eggs early. Lupron, ganirelix, cetrotide, those are some of the drugs that we use to suppress the pituitary. The stimulation part is with injectable medications. We still don't have strong enough drugs to give by mouth, so everyone will be learning how to do shots. Luckily, they're given subcutaneously with a small needle, almost like an allergy shot or an insulin shot. I can remember in my early days, my patients came in and we gave them daily IM shots to be able to do IVF. Well, everybody does it at home now. They do it in the airport. These are much simpler to administer than what it used to be. There are a lot of different protocols or combinations of medications. And this is where the doctor's responsibility is trying to decide what's the best combination that you would respond to, what's the best dose, we want enough, but not too many. How do we do that? Well, it's hard to do, and it changes from year to year. But that's why we go through a lot of testing and preparation so that we can do this effectively and safely. In general, most people respond in about 9 to 10 days. In fact, IVF in some cases is simpler than when I'm treating women with fertility shots, because when I use the fertility shots, and we're trying to do inseminations, I don't want 9 or 10 eggs to grow. I only want 2 or 3. And so I have to be very careful with the doses of medicine and adjust it, and it may take several weeks to do that. But with IVF, it's different. Here we know we want ideally 10, 12, 15 eggs to grow. So we're going to be using bigger doses. We're going to be watching the response with ultrasounds and blood tests. But most people respond in a fairly predictable fashion, and that makes it simpler. We come in and we start doing IVF. We set up all their appointments except for the retrieval and except for the transfer. And I always tell my patients, you know, we kind of know about when you're going to be ready, but your ovaries are the ones that decide when you're ready. So you've got to be flexible enough so that when I say, hey, we need to go another day or two, you don't say, I've got a meeting, I can't do it on that day. We want to do it to be successful. Sorry, I can't read my notes here. Let's go to the next slide. This is a picture of an ovary that is pretty stimulated through IVF. All those dark circles are a follicle. A follicle means that an egg is growing and maturing inside of it. We don't always get an egg or a mature egg from each follicle. How do we know when the eggs are ready? Depends on how many days we've been doing it. Depends on the size of the follicles, how high your estrogen levels are. But it's always an educated guess. So when we are trying to determine when the ovaries are ready, we're looking at the ovaries here on ultrasound and using that to try to determine when are most of the eggs going to be at a good mature stage and we can recover them. The egg retrieval is done in the office lab. Some programs do it in a hospital setting. I have an IVF lab that's just a part of our office. It's done under IV sedation, so you will be asleep, but this is not a general anesthetic. They do not need to help you breathe. You're just asleep. It's very nice control. I tell the guys, it's kind of like when you go in for a colonoscopy or endoscopy. You know, you're asleep while they do the procedure, but you will wake almost immediately afterwards. And then the ultrasound is done vaginally. The needle is guided alongside the probe into the ovaries. And there's only about 2 or 3 millimeters of tissue that separate the probe from the actual follicle itself. So the needle goes into the ovary. I take the fluid out of all the follicles, big ones and little ones. And in the laboratory, as we're doing this, the embryologist is looking through the fluid, identifying the eggs within. In most cases, that procedure just takes about 10 or 15 minutes. Once the eggs are recovered, they're going to be fertilized in some fashion later that day. If we have normal sperm counts, then many times we will surround the eggs with a concentration of sperm and let the sperm fertilize the eggs. In many situations, if the sperm count's not normal, if there are maybe not as many eggs present, if there's other reasons, we do this procedure called ICSI, where we actually inject a single sperm into the egg itself. And for couples that have extremely low sperm counts, this may be the only way those eggs can fertilize. Now, some of the concerns are, people always ask me, well, you know, isn't natural selection better? I mean, you know, naturally the sperm are going to win out in terms of who gets to the egg. Well, ICSI has been around for, gosh, 20-some years now. We have many, many series of patients who've been followed with this. ICSI does not seem to increase the risk of any health problems or birth defects, with one exception of there are some men that have very low sperm counts who would not be able to conceive otherwise, and we may be passing on some of their genetic traits. So they may be at a little higher risk of some chromosome problems or problems with the placement of the urethra called hypospadias. And I still have not had a couple that have come in and the husband say, well, I really don't want to have a kid. We're have children if they're gonna have the same problems as me. I'm a healthy adult, hopefully by the time they're adults, we're gonna have this infertility thing figured out, and we'll have to do it right. But ICSI is a very common way to fertilize eggs and be very successful. This is a picture of some of the stages of embryo development. They go from a single cell to dividing. By day 3, many embryos are about a 6 or 8 cell stage. And it is very easy to look at the embryos at that point and say, well, these are a little bit further ahead. And that used to be the day that we transferred most embryos. By day 3, we had a pretty good idea of who is doing the best. Well, now we can culture embryos to a much later stage of development, which is a blastocyst stage. That's when they're ready to attach to the uterus. It's usually around day 5 or day 6 after the egg retrieval. And so if we have enough fertilized eggs in the laboratory, if they're doing well, we will try to culture them to that stage and then choose between them. That's also the stage at which we typically would freeze the embryos if they're not transferred. So if we have a good number of embryos, blastocyst transfer is very good at helping to pick the ones that may have the best potential. However, if we don't have as many embryos, if the quality is maybe not as good as we think, you are still the best incubator in the world. So I would rather put those embryos back on day 3 because all we can do in the lab is try to mimic what your body does naturally. So that's the difference between a day 3 transfer and a day 5 transfer. It's purely that of selecting. So if there aren't as many, day 3 I think is better. If we've got enough embryos to go to day 5, then it may help us choose the ones that have the best potential. The embryo transfer is really very simple and straightforward, at least from your part. It's done very much like an insemination. You will be in the procedure room. The embryologist will bring in the catheter that has the embryos within. It will pass through the cervix up into the uterus. Usually you don't even feel it. It's such a soft catheter that you don't feel it. Most of us do an abdominal ultrasound just to confirm that the catheter is in the right part of the uterus. The embryos are placed. You go back to the recovery room for a short period of time, and then you go home. Embryos do not fall out of the uterus. Okay? Even though we draw it like there's a big open space and we're just putting them in there, yeah, I always consider it's more like when mom makes your bed and the sheets are folded over, and all we're doing is we're just slipping the catheter between the sheets of the bed. The layers of endometrium actually are touching each other, so the embryos are kind of placed in there. They're in contact with the layers of the endometrium. Back in the early days, they used to have women stay after the transfer. They put them in funny positions and stay for hours and hours. And nowadays, we probably let you up after about 10 or 15 minutes. Once they're in there, they're not going to go anywhere. The decision for the embryo to attach probably is determined more by the embryo than by anything else. And once we figure out how we can know which embryos are ready to attach, then it's going to be a whole lot easier to just put in one embryo at a time. If we have extra embryos, we definitely would recommend trying to freeze them. Freezing embryos does not harm them. There are no increased risk of birth defects, miscarriage, or problems with embryos that have been frozen versus those that have not. Nowadays, we tend to do it in a faster process called vitrification. Slow freezing was done for years and years and years. This is maybe a little bit more successful way to freeze embryos, and so most programs, I think, recommend that or try to do that. Why don't we freeze every embryo? Well, so many embryos really don't have the potential to survive the thawing process, and so back in the old days, we freeze all these embryos, and then when people came in and we thawed them and wanted to place them in, a lot of them didn't survive or weren't very good quality. So now I think we're much more selective, but also the pregnancy rates are higher for breeding. So if you don't have embryos to freeze, it's not a bad thing necessarily. We're putting in the ones that have the best potential, and if the others were not to that stage of development, they probably were not going to help you get pregnant at the beginning. But again, we hope to freeze extra embryos because those embryos could be stored. If you don't get pregnant on the first try, they could be thawed and transferred back. Using the frozen embryos is so much easier than IVF. Not stimulating the ovaries, there's not usually a lot of fertility shots, and very, very good success rates. This is a busy graph, and I'm not going to read all the numbers from it. SART is our kind of parent organization, and so they collect statistics from almost all of the IVF programs in the United States. It's very detailed reports, and there are good things and bad things about these reports. You know, it can give you very good ideas of, in general, what are my chances of getting pregnant through IVF based on my age. Age is still the most important determinant of success for IVF. So if you're under 35, it's definitely a lot different than if you're 39 or you're 42. And those are things that we can't change. And that's why we're trying to get the message out to patients, to physicians, that age is such an important part of infertility that people need to get into treatment sooner than later. And years ago, we had a campaign to try to educate people about the effects of age. Well, there was a big outcry. We were accused of scaring people into going into fertility treatment, when really the goal was just to educate people about how much your age affects the success. But what the CDC and what SART will report are pregnancy rates. It's based on if you just come in and get started, if you go through a retrieval, if you make it to the point of transfer, what's the chance of having a twin pregnancy nationally by doing that? Now, statistics are good and they're bad. They're great for the general population. For the individual person, statistics don't really mean that much. Your chance of having twins when we do this depends a lot on the quality of the embryos, how many we put in, and so every program and every patient situation is different. These are guidelines that help us choose the right number of embryos that will help you get pregnant. One of the other problems with these statistics is that everybody likes numbers. Okay? It's really easy to see, well, gee, he's got a 39% pregnancy rate, and they have a 41% pregnancy rate. So obviously they're 2% better than the program that has 39%. And that may or may not be true, because it depends a lot on the patients that we take care of. I have patients who have very good chances of getting pregnant, and some that don't have very good chances of getting pregnant, depending upon their ovaries, their sperm counts, a whole lot of factors. So it has sometimes led us into competition. Okay, now sometimes I think some programs are very worried about their pregnancy rates, and it's like, well, gee, I don't want you to go through IVF, because if you don't get pregnant, now my pregnancy rates are lower. And I disagree with that. I think most programs don't take that approach. But we are sometimes accused of that. But also, I think people overinterpret numbers and say, well, again, their pregnancy rates are better than the other one by a couple %, so therefore we ought to go to them. I think it really depends a lot on the program, their philosophy. And so, again, pregnancy rates, they're good to look at, they're helpful. When you go in to see the physician, I think it's a good question to talk about. What are your pregnancy rates? What are your philosophies about the patients that you take to the treatment or not? You'll also see on there it talks about cancellation rates. And they're pretty low for women under 35, and they're a lot higher as you get older. And what that means is that not everybody responds well to the fertility shots, even when we use high doses. And that is sometimes one of the limiting factors, so that as women get older and their ovaries have fewer eggs, they may not produce enough eggs for us to go in and be able to do an egg retrieval. We all have kind of little different set points. For me, I always feel more comfortable if I think we get at least 4 mature eggs when we go to retrieval. But again, it depends a lot on your situation. What's the average number of eggs we recover? Well, again, it depends. If you're under 35, I'd say a lot of times we're going to get maybe 12 or 13 eggs. If you're 41, 6 or 8 eggs might be a very good number for your response. And again, it's not all age dependent, because there are a number of women under age 35 that may get canceled because their ovaries just don't produce enough eggs. We do screening, we look at ovaries on ultrasound, we do blood tests. All of those are trying to predict the ovaries are responding. It doesn't mean you can or cannot get pregnant. And so when we talk about day-to-day FSH levels or NH levels, those are tests of what your ovarian reserve is, which means how well we think your ovaries are going to respond, but they're not absolute predictors. It may help you make decisions about going through treatment. If the doctor says, well, I'm worried you may not produce enough eggs, that may determine whether you're going to try it or not. But at least from my standpoint, I'm almost always willing to give you a chance, because if we can just get enough to where we can get hopefully 1 or 2 good quality embryos to put back, that's really the best chance for a pregnancy. We're going to branch off of there. So that's kind of nuts and bolts of IVF. We'll give my opinion, and we'll definitely take some questions at the end. Because again, IVF, very common in the United States. We probably do 100,000 cycles of IVF annually. And it's something that people should be educated about to help them make decisions about whether they do it and when they should do it. We're going to talk about pre-implantation genetic screening, pre-implantation genetic diagnosis, because these are some tools that may help us improve some of our pregnancy rates. And there are certain conditions where we should be helping couples go through this. What is the difference? Pre-implantation genetic screening means we don't know that you have a genetic disease, but we're worried about the number of chromosomes in the embryo. If the embryo has an abnormal number of chromosomes, most of them are not going to attach, or they could attach and result in an early pregnancy loss. The majority of miscarriages are because of chromosome problems in that embryo. And then, or the third would be if there was an abnormal number of chromosomes, then it could result in the birth of a child. For instance, Down syndrome is an extra 21 chromosome. Turner syndrome is missing an X chromosome. So there are certain conditions where even if the number of chromosomes is abnormal, it could result in the birth of a child, but they may have some health problems associated with it. PGD is a little different in that stands for pre-implantation genetic diagnosis. So it means that you know that you have or you're a carrier of a genetic disease. For instance, cystic fibrosis, thalassemia, sickle cell disease. There's a whole host of genetic diseases that now we know not only what the inheritance is, but also what gene is causing that problem. So it means that we can, if we know what gene is involved, and if they can create a probe to identify that gene, then we could do IVF and be able to identify the embryos that might have that disease, and therefore we would not want to transfer them. And more importantly, identify the embryos that don't have that disease. And in fact, I saw in the news just recently, a woman who had a baby that had a very serious health problem, and again, she had a healthy child and then she had an affected child. So this was a recessive trait. She had no idea she was a carrier of that, and her husband was, and she would probably not have another baby unless there was a way to know that the next child wouldn't have that disease. And now we can do that, which I think is just an amazing thing. Why do we do PGS, or who needs this? Probably age is the most important part of that. And I've got some slides that just show how common abnormal chromosomes are related to age. More and more, couples that have repetitive miscarriages, when we do all of the other testing and we look for antibodies and problems with the uterus and hormonal issues, and none of those seem to be causing you to continue to have miscarriages, there's pretty good evidence that for this couple, for whatever reason, they seem to have embryos that make chromosome problems much more common than everybody else. And so by doing PGS, we can identify the embryos that would be normal and help them avoid a miscarriage. So again, these are couples that are not having trouble getting pregnant, but they keep miscarrying. Well, now we can actually do something about it and just say, we'll just keep trying, we'll try these other things. There is some indications that when you keep going through IVF, and if you're not getting pregnant, that we may be selecting the wrong embryos based on their appearance. And I'll show some slides about that. So, PGD again tests for people that have some known disease. It could be, if there's all kinds of recessive dominant genes, some that are just carried on the X chromosome, some couples that may have, they know one of you carry an abnormal chromosome. Again, these are reasons that we do this. And again, you have to know what is the gene that's causing it. Well, now we know a lot of the genetic diseases, the genes that are responsible for that. There's also some situations where you may have a chromosome that confers a risk of disease. BRCA is one of those. It's a risk of both breast disease, breast cancer, and ovarian cancer. So there are some people that are being identified. Maybe they have a strong family history of breast cancer. They come in, they do this testing, they go, oh, I've got this gene that increases my risk of breast cancer and ovarian cancer, and it may increase it for my children as well. So again, this is a situation where we can try to prevent that. Now you notice I don't have up here eye color, hair color, success in school. This is what we read about in the newspaper about, oh, this is why we shouldn't do these procedures. People are coming in and they're ordering babies that have blue eyes and blonde hair, and they're 6 feet or 6'6", and you know what? That just doesn't happen. This is hard enough to do that we do it for very specific reasons. So I am not concerned that we're going to have these designer babies. Now I live in the Midwest. Maybe it's different in California and New York, but again, the reasons to do these tests are that it is trying to prevent disease, and that's what we're doing. How do we do it? It's pretty amazing, and I still like to go into the lab and watch my embryologists do this. The picture on the left is how we used to do it more commonly. We would remove usually one cell from a day 3 embryo. So there were only 6 or 8 cells there at a time. And we make a little hole inside of the embryo, the covering, and then they remove one of those 8 cells. That cell would get sent to a laboratory. Usually took about 2 days turnaround to find out if that gene was present or if the number of chromosomes was normal or not. And then hopefully that embryo would continue to develop so that by day 5, when we have the results back, we would say, okay, these are the normal ones, these are the abnormal ones, we're going to transfer the normal ones. More and more, we are biopsying embryos when they're at a blastocyst stage. So here they are, day 5, day 6, and the advantage of the blastocyst biopsy is that there's a whole lot more cells there. Okay, so instead of taking 1 out of 8 cells, this embryo has maybe 100 to 120 cells, and so again, we make that small little opening, we remove 3, 4, 5 cells. So now the laboratory is not banking everything on just 1 cell. They've got 4 or 5 cells to analyze. And also, remarkably, we're finding that the day 5 biopsy seems to be a lot more accurate. We kind of debated, why is that so? Why is it when we did a day 3 biopsy, sometimes it would show that the chromosomes were abnormal, and then in some of these studies, they had to re-biopsy the embryo at day 5, and they go, well, that chromosome problem is no longer there on day 5. Was it just there was only 1 cell involved? Was it the embryo kind of, as it continues to develop, gets rid of abnormal cells? But a day 5 biopsy or blastocyst biopsy seems to be more accurate. Now, when we do that, it usually means that we are committing those embryos to being frozen and then transferring them at a later time. And actually, success rates may be better if we do that. So it's not a bad thing to just freeze the embryos and not transfer them. The important thing is finding out, are they normal or are they not? I'm going to have to read these slides. Don't memorize. A couple of studies that I found about PGS that I thought were pretty interesting. The first one talked about an IVF laboratory where they picked the embryos that they thought were the best that they were going to transfer on that day. And they said, okay, here's the 2 we were going to put in. And then they did PGS. And guess what? Some of those weren't chromosomally normal. Remember, under the microscope, they all look the same. You can't see the chromosomes, we don't know which ones are normal or not. Now, if you're under age 35, only about 1 out of 7 of those may not have the right number of embryos or chromosomes, which is aneuploid. But if you're over 35, 1/3 of the embryos that we were putting in actually really didn't even have a chance to become a pregnancy or be a successful pregnancy. Same holds true as women get older because the chromosome issues are more common. If you did PGS and biopsy the embryos rather than just putting in the ones that you thought looked best, it was about double the chance of having a baby from that. Not just a clinical pregnancy, but actually delivering a baby. So again, it is used very commonly in that situation. And then we have debated among ourselves about for people that go through IVF and they're not successful, and we've done it several times, well, again, is it that we're selecting the wrong embryos? So for people that have had several failed IVF cycles, again, it may be a better success rate. That study said that wasn't a significant difference. That looks like a significant difference for me, 48% versus 28%. But again, in statistics, that wasn't quite to the point where they thought that they could clearly say it was better. Now, that study, when they did that, so here are the people that have done IVF several times, the majority of embryos actually have chromosome issues. So that may have been why they kept failing. So again, it's another reason to consider, should I do PGS? Now, I don't think that everybody needs to do PGS. PGS is an invasive procedure. We're biopsying the embryo and taking cells out. But it does have some advantages, especially in certain situations like this. And again, age is very much a part of how likely are we going to find abnormal chromosomes. If you're under 35, this study is 1 out of 5, and the other one, remember, is about 1 out of 7. But once you get to about age 38 or older, almost half the embryos may have chromosome mistakes. And again, doing PGS may help us pick the ones that really have the potential to be a healthy baby. And then this is maybe the most exciting one I found, but it still has some limitations. This is where they looked at couples going through IVF and they were all doing PGS. And they said, okay, well, when we knew we had normal embryos by PGS, how much was age an effect of the success of this? So if you were under 35, 64% got pregnant that we put into quality embryo. If you were age 41 and 42, it was almost the same. There was there was nowhere near the drop off in age if you were putting in the chromosome with normal embryos. But the sobering fact is to the right, where not every couple had normal embryos to transfer. And so as you got older, even though you want to do this, only 29% of those age 41 or 42 actually got pregnant because the majority of them didn't produce enough embryos or didn't have normal embryos to begin with. So PGS is such a great idea and it's a wonderful technology, but the people who would benefit the most from it, which are going to be the older women, are the ones that are least likely to have enough eggs and enough embryos to make it successful. So that's the good news and the bad. I offer PGS. I make it known to all my patients. I really start to recommend it when I think age is a factor, miscarriage is a factor, or they've had IVF failures. And again, it's something that can make it more successful. I think it's just something you need to talk to your doctor about. And that's really kind of the meat of my talk today. I thought I'd leave a lot of time for questions because everybody has questions about IVF. IVF, again, it's a very common procedure, very successful, very expensive. It is least likely to be covered by insurance. Most of us that do it, we have some help for you in terms of some way to finance or pay for it. Because again, it's something that we all believe in. It's not what I do on all my patients. Okay? We are not just an IVF laboratory. We still get most of our pregnancies through all the other means. But in many cases, if other treatments aren't working, if you've got certain reasons such as sperm counts that are too low or problems with the tubes, IVF may be how you should start. Anyway, I'll throw it open to questions. hyperstimulation. Ovarian hyperstimulation means that once we do the egg retrieval, the ovaries continue to enlarge and they can get to a point where they start to pull fluid into the abdomen. It can be a very dangerous situation. Women who are at risk of that tend to be younger, often women with polycystic ovaries, those that produce a lot of eggs. Sometimes you don't have PCOS, but if we look at your ovaries on ultrasound, they may look the same as someone with PCOS. So those people are at increased risk. We try to identify that again by some of those tests that we did before. And the good news is there is now a protocol, or some protocols of medications that reportedly completely eliminate that risk. Okay, I'll never say completely, but I think that the chance of hyperstimulation, when we know in advance that you're at risk for that, we can pretty much minimize that. And I'll give the story of, I had a nice young lady who I knew she had polycystic ovaries, and I put her on probably the lowest dose of medication I've ever used, and her ovaries just exploded on that. They got so many follicles and so big that we didn't even go to retrieval. I said, it is just too dangerous even to continue, so we stopped. And I brought her back another time, tried an even lower dose, exact same thing. And so then when this new protocol came out, she went through it, was able to get pregnant, had no significant symptoms. You know, everybody that does IVF has some hyperstimulation because that's what we're doing. We're making the ovaries big. You're going to feel kind of uncomfortable. We don't want you running and doing things. But the significant hyperstimulation syndrome that we're talking about ought to be pretty rare, and we ought to be able to prevent it in most patients. Did that answer your question? Yes.
What is your target number of follicles going through IVF?
Okay.
And-
Go ahead.
Sorry, and how many hours after trigger?
Okay. The questions are, how many follicles, what's the target number, and how many hours after the trigger shot do we do the retrieval? I do the retrieval roughly 35 hours. Most of us do it somewhere between 34 to 37. You know, there's a little bit of leeway of time built in there so that it's not like, hey, if we don't get into the retrieval room right at the time we said, the eggs are not going to release. And again, the question, people go, well, why are you trying to release the eggs? We give the trigger shot not to release the eggs, but to get them to start back into meiosis and go through their maturation. And that's really when they begin to release from the wall of the follicle, so they're easier to recover. So it's very specifically timed so that you take the trigger shot, and then we need to do the retrieval at a specific time. Target number of eggs. You know, I wish we could just dial it in. I wish there was, I saw you and I go, okay, if you're on this dose, you're going to make this many eggs. In my experience, I always hope to get about 12 to 15 eggs because I think that most couples that have about that many are going to have some very good quality embryos for transfer. We're probably going to freeze a small number as well. And you go, well, why don't you give more? You know, why isn't more better? Okay, more may not be better because number one, your estrogen levels may be a lot higher, which could affect the endometrium and maybe make it harder for them to attach. That's kind of our new thought. Number two, it increases the risk of hyperstimulation. And number three, not everybody wants to have a whole lot of embryos, stored. I mean, that's one of the other concerns is that I want to get pregnant, but I don't want to have so many embryos remaining that I don't know what to do. And in fact, one of my med school classmates called me a number of years ago. She'd done IVF. She'd been successful. She had twins. Then she got pregnant on her own after that. And she had a number of frozen embryos. And her laboratory contacted her and they said, well, you've got to use them or we're going to discard them or, do whatever. And so even though she had as many kids as she wanted, she didn't know what to do with those extra embryos. And I was able to help her figure out what to do with them. But that is a concern. So again, you want to have whatever is a safe number, not too many. Now, some things that we can do recently that are going to help in that situation is that we are able to freeze eggs now, which for many, many years we couldn't do that. We could freeze sperm, we could freeze embryos, but eggs are very delicate in terms of surviving the freezing process. concerns is, I don't want to have too many embryos. You know, what happens if we've got 21 eggs? And they go, well, I don't want them all fertile. We can freeze some of those eggs. The advantage of that is, well, once they're frozen, let's say they did IVF, they weren't successful, and they go, boy, I wish we used those eggs. We can thaw those eggs, fertilize them, so you don't have to go back to IVF to do that. And that's a very exciting new part of what we're doing in the United States. I still consider it not as secure as fertilizing an egg. So yeah, I'd rather have an embryo to freeze than an egg. But in those situations, I think given enough eggs, we can help them through a pregnancy. Other questions?
In regards to your PGS, they talk a lot of, you spoke about how age can affect the, chromosome rates, but in regards to recurrent miscarriages and age, is there any correlation with younger women who suffer from recurrent loss of the number of healthy embryos they produce versus an older woman who has recurrent loss?
You know, it's a good question, and I don't know that I have the answer to that. I think that just age alone is more likely to result in losses from chromosome loss. But again, there are some older couples that may have those same issues. So I can't say if you're 28 with recurrent miscarriages and you're 38 with recurrent miscarriages, which one is, what's the percentage of man normal embryos? It may be the same.
And then my other part is that if you, what percentage, I don't know if this is answerable either, but what percentage, we're about to start our first cycle of IVF, and I'm a woman who has many different losses, but, what is the percentage of women who have recurrent loss that you will have, and we're planning to do PGS, and we'll have no eggs that are of good quality?
Good question. One of the studies I quoted found that when couples went through PGS, now this was again not necessarily for recurrent miscarriages, they had 3% that had all abnormal chromosomes. But again, I think it's very age-related, and that's one of the concerns is that if you did IVF, what if they're all abnormal? Well, it's good news and bad news. If we had not done the testing, we'd have had embryos transferred, we'd have frozen embryos, we'd have come back, we'd have done frozen transfers, we probably wouldn't have gotten pregnant or had a miscarriage. So it is helpful to at least know that in advance. But I also don't believe, well, if we did that, and this time you had 8 embryos and they were all abnormal, well, I wouldn't tell you, oh, you can't do that again, you're never going to have a baby. I just don't believe that's true. I think that if we came back and did it again, I think we would be just as likely or more likely to have some that are going to be normal embryos. So again, if you can produce enough eggs and embryos, it's going to help your chances. And that's where age hurts us, because the people, again, who really need that testing the most, they have trouble producing very many eggs and embryos that are suitable for lives. Other questions? Yes.
I'm not quite sure if I'm going to word this correctly. I actually did IVF cycles before. And the first one, I guess I always try and figure out why things happen, even when there's no answer to it. I feel like the first one, we did 3 cycles, 2 fresh, 1 frozen. I feel like I'm a very hormonal person to begin with. And I think I'm trying to find a correlation that maybe all those hormones affecting me, and that's why they didn't work. Are you finding any correlation between hormones and implantation? Like, I somehow got pregnant on my own, no fertility drugs, no hormones, nothing. So I didn't know, like I said, I'm trying to find a correlation
Sure,
to make
you
myself
bet.
feel better.
So the question is, and also, is that likely because I was able to get pregnant without, I got pregnant without the treatment, I didn't get pregnant with the treatment, well, obviously, these are concerned about it. One thing I remind everybody is that most of the couples that are struggling to get pregnant do not have absolute barriers to fertility. Okay? If you have no tubes or block tubes, if you have 0 sperm, if you have no uterus, you can't get pregnant. Everybody else can. And so most of the things that we treat are couples that have things making it harder to get pregnant, but not absolute. So if we did nothing at all, and if you gotten married or tried to get pregnant when you were a teenager, this is where I go back and read old literature, and it's like a lot of couples have been married for 40 years and they had one child. Okay? 40 years of no birth control in their whole life, and guess what? They had a baby at some point. Okay? Maybe she had polycystic ovaries. Maybe she had something else going on. So the things that we do are hopefully helping to increase the chance of getting pregnant. Again, they're not absolute either, so I still have a treatment that's 94% or 100% or whatever. So there are a number of people that, given enough time, if they're not on treatment, definitely can get pregnant on their own. Does not seem to be an increased chance, like right after treatment. Some people say, well, I got pregnant right after I did some treatment, and so it kind of helped boost me. I think it's really just coincidence. Now, regarding the hormones involved, yeah, we're very interested in the hormone levels that are produced when you're going through IVF. And in fact, there's some exciting new information about, well, because when we do IVF, your hormone levels are elevated, it may affect the endometrium and may affect attachment of the embryos. So that's why we're getting 60% pregnancy rates and not 90% pregnancy rates. And some programs are even going to the point where they retrieve the eggs, they freeze the embryos, and then they're going to come back in another cycle where they're controlling the hormone levels in the endometrium better. Okay? So is that where we ought to go for everybody? Probably not. I still think there's probably some specific situations where this may benefit couples. So again, you may read about that, but people are going to say, hey, what's this about freeze-all? You know, why are you doing some compression embryos? It just depends. So I have to say, maybe yes, maybe no. All right, I think I'm going to have to wrap it up.
Yeah.
Thank you for your attention. If you have more questions, you can always catch me on break.
Another little 10-minute break. This is the last call to put your names in the tables for the baskets in the booths. So make sure you get your names in there. Grab some food or drink, go to the back.